speaker, Dr. Hatem Elshora, who is my colleague, and it's my honor to be his colleague in Tanta University Hospital. He is currently a lecturer of anesthesia and critical care at Tanta University. He has a Master of Science, he has MD, and he has European Diploma of Anesthesia and Critical Care. He traveled to the United Kingdom 3 years ago, and he's currently working as a locum consultant in anesthesia and critical care in the University Hospitals of Leicester. So his main interest and publications are all, or almost all of them, in cardiac anesthesia. So he's talking to us tonight about anesthesia for CABG patients, or for coronary artery bypass grafting and perioperative assessment and management. So Dr. Hatem, please go ahead and start sharing your presentation.
Thank you, Dr. Lead. Thank you, Dr. Ashraf. It was a very juicy presentation that you did today. It's very informative indeed. It's a great honor to be among this highly respectful panelists and highly respectable faculty of this course. Without further ado, I'm going to crack on. So today we are going to speak about anesthesia for CABG, or coronary artery bypass graft. And next week, inshallah, we are going to cover anesthesia for valvular heart disease. So when I started to search about the objective for this presentation, this is what I get on. And I found that the American Heart Association had similar finding about the optimal anesthesia care in patients who are undergoing CABG. And all these patients should have a careful preoperative evaluation and the treatments of modifiable risk factor and risk stratification. All these patients should have a proper handling of all medication given preoperatively, establishment of central venous access and careful cardiovascular monitoring, induction of a state of unconsciousness and anesthesia, and finally smooth transition into the ITU later on with the goal of early extubation and faster tracking. The national audits, cardiac audits done here in the UK showed that the most common procedure done in cardiac surgery is isolated coronary artery bypass graft, or CABG. And the total number of patients who did CABG in the UK have declined from nearly 17,000 patients into 14,000 patients. And the reason for this decline is the improvements in the primary care prevention, plus more patients are going for a less invasive PCIs. However, this doesn't mean that CABG is going to diminish in the next coming years, because the role of CABG will always be resistant for emergency patients, patients who are not feasible for PCIs, and for complicated patients after having a PCI, like dissection of the stenting and all of these. So the preoperative evaluation for any patient who's going to CABG, the European Society of Cardiologists had a wonderful guideline regarding patients who are having a chronic coronary syndrome. And what caught my eyes, their six-step approach for assessing patients who have a chronic coronary syndrome. Step one is assessing the symptoms and perform clinical investigation, whether these patients have acute coronary syndrome or not. If they have acute coronary syndrome, they should have their own pathway. If not, and this is a chronic condition which is persistent, then we should check the quality of life of the patient and their comorbidities. As us, the anesthetists, are not only confined to the theater of the patient and taking the patient to theater and delivering to the ITU, our role should be more inclusive and should involve the preoperative assessment of the patient and the discussion as an NDT with a cardiac surgeon and the cardiologist. It's well known that any patient who is independent before having a major elective procedure, their general condition will markedly decline immediately after having a cardiac surgery. And if uncomplicated, they should do a recovery within at least 3 to 6 months to their baseline. But if the patient have a very poor quality of life, offering them a revascularization will be futile, and these patients should be for a medical therapy. And this should be a discussion between anesthetist, cardiac surgeon, cardiologist, and of course the patient himself. If this is not the case and the patients have a decent quality of life before having the chronic coronary syndrome, then the baseline investigation like ECG, biochemistry, chest X-ray, echocardiography are addressed in order to assess the left ventricular function, assess the probability and whether the patient is going for a CT angiography or invasive angiography in order to detect which vessels are mainly involved, and lastly, choose the appropriate therapy, whether going for a less invasive PCI or going for a CABG, and this depends on the patient risks. For us, what are the most important high risk of these patients? So I would say that stress echocardiography showing more than 3 segments of hypokinesia or akinesia, or cardiac MRI showing more than 2 segments or more than 3 segments if dopamine-induced dysfunctional segment, or coronary CT angiography or PCI showing 3 vessel disease or left main disease or proximal anterior descending disease, all of these should be a high-risk patient which should be treated cautiously. The most validated score for preoperative risk stratification in cardiac surgery, which is well investigated, is the Euro score. And as you can all see, it have multiple variables: the patient's age, gender, preoperative comorbidities like renal impairments, diabetes, peripheral vascular disease, COPD, the urgency of the operation, whether it's elective or emergency, and how is the LV. All of these will give you an idea about the preoperative risk, mortality, and morbidity. And based on this, we will have our discussion with the patient whether to proceed on the surgery or to go for a less invasive. Management of the preoperative medication. As we all know that most of the patients who have a chronic coronary syndrome or having angina attacks, they are on beta blockers. And the benefit of having beta blockers, with or without previous MIs, undergoing CABG, beta blocker will be associated with less risk of mortality and adverse cardiovascular events. However, the sudden stoppage of the beta blocker should be inhibited at all, because this will be associated with a reflex tachycardia, as well as will increase hypertension, which is not beneficial in patients who are subjected to having an MI. So continuing the beta blocker for at least 24 hours before cardiac surgery is highly advisable. And restarting the beta blockers in day 1 or day 2 after the surgery is highly advisable, as long as there is no contraindication from hypotension or severe bradycardia. All patients with chronic coronary syndrome should be on antiplatelet one way or another. So aspirin is normally continued in patients with chronic care syndrome undergoing elective cardiac surgery till the day of the operation. And other antithrombotic medication like clopidogrel or ticagrelor should be stopped according to the plasma half-life as well as the renal function, whether 5 days or 3 days. Some patients might be on DOACs as well if these patients are having a coexisting AF as well, and these should be stopped 1 to 2 days according to the dose and the renal function as well. If the patients have a critical left main, most of these patients are on heparin infusion, and if this is the case, it should be balanced between the risk of left main obstruction versus the risk of bleeding, and most of these patients will stop the heparin 2 to 4 hours before the operation. ACE inhibitors can reduce mortality, MI, stroke, and heart failure in patients with LV dysfunction and peripheral vascular disease. However, ACE inhibitor, as it's well known, and I believe that this has been covered in the lecture of cardiac for non-cardiac, which Dr. Amr Hatem already did 2 weeks back. If you miss it, I strongly recommend you go and see it. ACE inhibitors are associated with high risk of intraoperative hypotension, and most of the patients who are going for cardiac surgery as well have a higher risk of vasoplegia as well. So it should be stopped according to the plasma half-life as well. Getting the patients on the day of the surgery into the anesthetic room can be associated with higher risk of anxiety, tension, tachycardia, hypertension. All of these can induce the risk of preoperative ischemia, which is not a good thing. So taking the patient into the theater, you can assess whether to give these patients anxiolytics at the night or the day before the surgery. However, it is not a routine in our center. And once the patient is in the anesthetic room, you can give the patients small dose of benzodiazepines like midazolam just to relieve the anxiety of these patients. The most appropriate anxiolytic is the direct connection which you have with the patient and start speaking to them and try to relieve the pressure. Once the patient is in the anesthetic room, starting the full anesthesia of Great Britain Association guidelines monitoring. So starting ECG, 5 lead ECG, including lead 2, lead 5, which have a great susceptibility of picking up ischemic changes, pulse oximeter, temperature probing once the patient is asleep, and we usually use nasopharyngeal probing, arterial monitoring, and usually we use invasive arterial monitoring. And it depends on your center. So if your center is using the radial artery for revascularization, you should have a discussion with the surgeon on the day of the surgery whether they are going to harvest the radial artery or not, because this will affect your option, which side that you are going to cannulate, the radial side. Most appropriately, we use a single line radial artery, but in some occasion we can use more than one arterial line. This is if the patients have a higher risk of coming off intra-aortic balloon or something like that, just as a conduit. Once the patient is asleep, a central venous pressure monitoring should be a routine for all of these patients, and it helps us very much during the weaning from cardiopulmonary bypass, and it will give us an idea about the accommodation of the heart, how fast are we filling the heart, and how the right ventricle function is doing in combination with other monitoring. Central nervous system monitoring are highly advisable. So according to the American College of Cardiology guidelines for the CABG, which was published in 2011, patients should have or may have central nervous system monitoring. And the simplest form is the processed EEG in the form of a PSI or BES or something like that, because it gives us an idea about whether what is the depths of anesthesia that the patient is subjected to. We know that patients who are undergoing cardiac surgery have a higher risk of recall and awareness. And all of these patients with this risk, we should have a validated monitor or some sort of monitoring which help us in order to titrate our anesthetics and titrate the patient depths of sleep. The other monitor which can be used as well and can be classified as level 2B is the near-infrared spectroscopy. The near-infrared spectroscopy gives us an idea about the global cerebral oxygenation and the global cerebral vasculature as well. And it has been found in multiple randomized trials that in high selective group of patients, if monitoring is done and intervention is done based on it, it can reduce the risk of the post-operative cognitive dysfunction as well as post-operative strokes. All patients undergoing cardiac surgery will have heparin at one point or another. Then monitoring of coagulation is very important in these patients. So we are doing what's called as activated clotting time. And the aim is to monitor the baseline coagulation of the patient, whether the heparin is working efficiently or not, and after reversibility of the heparin, whether we have come back again into the baseline that we started with or not. There are different techniques and different machines which are used in the cardiac theaters. Point of care coagulation monitoring. Dr. Magdi Khalil last week done a very interesting presentation about trauma patients and coagulation in trauma patients, and he spoke thoroughly about TEG, ROTEMs, and different curves. And if you missed this lecture, I strongly recommend for you as well in order to go and see it on the YouTube. And he showed the different figures and the different shapes of the ROTEMs and the TEG, and according to which we can treat the patient. So why the point of care of coagulation are very important in cardiac surgery? I would say that most of these patients are elderly. Most of them are on single or dual antiplatelet medication. They are subjected to hypothermia, going to cardiopulmonary bypass, which cause consumption of the coagulation, consumption of the fibrinogen, as well as dysfunction of the platelets. All of these factors, in addition to a surgeon with a knife working in a major vessel like the aorta or the heart, are associated with increased risk of the bleeding. So knowing which factor is missing, you can hammer it with the treatment. Other rule of thumb, if it's R time or K time, which is prolonged, it's coagulation deficiency, and the MA time represents the platelets and the fibrinogen, and the lysis, you can treat it with antifibrinolytic therapy if needed. Transvagal echo monitoring started in cardiac theaters. However, its use has been expanded more and more in non-cardiac theaters. Right now, it's used in thoracic, high-risk vascular patient as well as a hepatic patient. So the use of, and definitely in the ITU. So the use of TUE is not limited to cardiac theaters. However, the American Heart Association give the use, intraoperative use of transvagal echo for monitoring with hemodynamic status, ventricular function, regional motion abnormality, and valvular function class 2A, and it should be used. So the transvagal echo can be used, as Dr. Ashraf Tayar would give us the last lecture. He was showing lots and lots of echo images. So all what you need to do is just to flip these images, which you saw in the previous lecture, upside down, and it will be exactly the same. So the top one is the transvagal mid-esophageal four-chamber view, and you can see the contractility of the left ventricle. So you assess the contractility of the left ventricle, the right ventricle. You can assess the filling status as well. So if you can see at the bottom picture, this is the left ventricle. This is a transgastric short axis view, and you can see that the whole wall of the heart of the left ventricle is contracting and squeezing. And you can assess that the intravascular volume in here might be low because you can see a kissing capillary muscle. So TUE gave us a good idea about the filling status, gave us a good idea about the condition of the valves. If you convert the first image to the left, which is the contractility of the left ventricle, to the second image to the right, you can clearly see that this wall is not contracting well. And there is anterior and anteroseptal wall hypokinesia. Actually, you can actually see it's hyperechoic in here, representing scarring of the anterior myocardial wall as a result of ischemia. So TUE have a great importance in the assessment of ventricular function. If you are doing CABG, you should be able to scan all the valves as well, because it is not uncommon when you are scanning a patient, you can find abnormality in other valves as well. So I put in here assessment of the aortic valve, but in next week we are going to speak about other valves and anesthesia for valvular heart disease, and we're going to speak about thoroughly. So you can see that this is aortic valve, Mercedes sign, and you can see that it's a competent valve which is not leaking, and there is no regurg in it. If you compare the first image with aortic valve in here and in here, you can clearly see here there is 3 cusps, right coronary cusp, left coronary cusp, and the non-coronary. And here we can only see 2 cusp, which is bicuspid aortic valve. You can see that it's calcific, stenose, not opening properly, and there is acceleration in the flow across during systole, which is subjected to aortic stenosis. And in long axis view, you can see that there is a leaking valve as well. So without doing a TUE, and if this patient didn't have a TTE for an emergency or something like that, you might miss something which can be corrected in the theater as a same session. Last thing which is very beneficial in using TUE in cardiac theaters in general, and if it's a complex CABG plus valvular heart disease, is the airing of the heart. So all these bubbles in the left atrium, in the left ventricle, as well as here in the aortic roots are air. And it's our responsibility with the surgeon to have a direct communication in order to be 100% sure that we have done a proper de-airing of the heart before fully weaning from the cardiopulmonary bypass. Because all of this air, if left unvented, will be going into the coronaries, leading to another ischemic attack, or going to the brain, leading to a stroke. Induction and maintenance. I hope that I can tell you that there is a perfect recipe which you can give for induction for these patients, but unfortunately there is nothing like a perfect recipe. What I can tell you that you have a hemodynamic goals which you need to achieve. Avoid tachycardia, avoid hypertension, especially in left main and proximal LAD disease. Whatever you can use have been subjected to great change. So early in the 70s, they started with a very high dose of opioids. And later on, they become more and more and more towards a more balanced anesthetics, slightly higher in the opioids, and with achieving these goals, avoiding tachycardia and avoiding hypertension. For most patients, you should have a clear plan about what we are going to do with this patient regarding their induction till the extubation in the ITU, because it's quite common right now. We are going for a fast-track protocol with early extubation when applicable, especially if this patient is low risk or even a moderate risk. Maintenance of anesthetic have been subjected to a lot of debates. So some will prefer using the TIVA, some will prefer using the volatile anesthetic. However, the volatile anesthetic-based regimen can be useful in facilitating early extubation and preventing patient recall, and this level of evidence A. Additionally, and superior to the TIVA, volatile anesthetic agents have increasing evidence of preconditioning effect. And the preconditioning effect is one of the myocardial preservative, which we will speak on later. The use of antifibrinolytic therapy have been validated in trauma patients and in cardiac surgery as well, as most of the patients have high risk of bleeding, as we have already said, and most of these patients have high risk of blood transfusion. So the use of antifibrinolytic therapy have reduced the risk of bleeding, plus reduced the risk of blood transfusion as well. And there are multiple protocols which can be used. I would say that the use of antifibrinolytic therapy should be judged against the risk of the bleeding, because antifibrinolytic therapy doesn't come without complication. So there is high risk of complication of obstruction or thrombosis of the newly stitched graft. And the most common, which we usually complication that can be seen in the ITU later on is seizures following the use of tranexamic acid. However, if it's balanced right and the risk have been already taken, usually it's very commonly used. There are 5 painful stimuli during cardiac surgery, starting with a skin incision, sternotomy, sternal retraction, pericardiotomy, and aortic cannulation. And as long as you understand all of these conditions, you should be titrating your anesthetics and your analgesic medication as well in order to avoid the shooting of the heart rate and the blood pressure during these events. You should be able to maintain a stable hemodynamic without shooting up or down during these 5 sessions. This being said, during the period of harvesting of the left internal mammary artery, which is the most common conduit used for coronary revascularization, this is the period of least vascular stimulus and least painful stimulus. So again, you should be able to titrate your analgesic medication, and using the processed EEG will be very beneficial during that. There are multiple tricks that you can do in order to help the surgeon when they are harvesting the lima: low tidal volume ventilation with no PEEP during lima dissection, giving heparin before the surgeon is clamping to avoid thrombosis of the newly harvested internal mammary artery. And finally, you should be aware that some surgeon can be injecting papaverine into the left internal mammary artery, which can cause vasodilatation and systemic hypotension as well. As I said, American College of Cardiology have nice guidelines about anesthesia for CABG, and they have discussed about the intraoperative myocardial ischemia. And the goals is to maintain the coronary perfusion pressure, a decent heart rate, intravascular status, and adequate oxygen. And if any of this happens, if there is hypotension and tachycardia, try to deepen your anesthetics depending on your processed EEG. Use selective beta blocker like Ismolor or GTN if needed. If the patient is hypotensive and tachycardic, you can use alpha agonist like phenylephrine. And if the patient is hypotensive with normal heart rate, you can use alpha agonist or lighten your anesthetics or use ephedrine or very likely atropine. Cannulation is one of the points which have special consideration. So when the surgeon is doing their aortic cannulation, special care should be given to the systolic arterial blood pressure. You should try to keep your blood pressure around 100 to 90 systolic to avoid bleeding for the surgeon, to give them and to avoid the risk of the aortic dissection as well, because there is high risk of dissection if there is an extensive hypertension during the time of aortic cannulation. And this is not a very good situation to be in. The second point that you should be aware about is the point of venous cannulation when the surgeon is doing their venous cannula, whether it's 2 cannulae in the superior and inferior vena cava or a single double stage cannula. There is multiple cardiac handling, and during that period, there might be risk of arrhythmias and hypotension. You should be aware that most of these arrhythmias are self-limited and they are terminated once the surgeon stops their handling, and most of the hypotension as well can be relieved by either giving an alpha agonist or giving them a fluid bolus from the bypass. Once the circuit is complete, then we can be going safely to cardiopulmonary bypass, provided that we have reached a decent ACT, which according to the European Society of Cardiothoracic Anesthesia should be more than 400 to 480 in different institutions. As you can see here, all venous blood is coming from the venous side of the heart, going to a venous reservoir, and from which to a venous pump oxygenator, and then the temperature of the blood can be changed into either cooled if you want to cool the blood, or heated back on again if you want to rewarm the patient, into arterial cannula. There might be an accessory pump like cardiotomy suckers in order to suck all the blood from the heart, or a cardioplegia pump in order to give the blood cardioplegia into the aortic root. Preoperative myocardial protection is one of the critical points which should have a great understanding about, and the British Journal of Anesthesia had a nice publication about in 2009. And the bottom line, in myocardial protection, there are multiple techniques that it can be used. Hypothermia itself can reduce the oxygen requirement of the heart. So by reducing the temperature of the heart from normal temperature into 22, can reduce oxygen demand from 80 ml per 100 milligram of the heart per minute into 0.3 ml of oxygen, which is a marked reduction in oxygen demand. Cardioplegia, which is usually rich in potassium, rich in magnesium, rich in bicarbonate, and local anesthetic as well. And there are a different constitution of it, can reduce electrical activity or stop the electrical activity of the heart, which will further reduce the myocardial oxygen demand. Venting of the heart and reducing the volume of the heart can reduce the tension on the walls, which by Laplace will reduce oxygen demand as well. And here comes the term of ischemic preconditioning and ischemic post-conditioning. So preconditioning is a molecular change which occur at the level of the heart, causing the heart to be more susceptible to ischemia and reducing the risk of infarction when subjected to it. There are a couple of methods which you can use for ischemic preconditioning, from remote preconditioning using our anesthetics like traditional anesthetics or opiate, or direct and local ischemic preconditioning, which is done by the surgeon by using clamping of the coronary artery for a few minutes and then reperfusion for another few minutes and then reclamping again for 3 minutes and reperfusion. Ischemic post-conditioning, despite the fact that it's not commonly used, however, it can be done again like the direct ischemic preconditioning by occlusion of the coronary artery and revascularization for a few minutes. Once the surgeon has already finished all the work, then it's time to come off the bypass. Next week lecture, we should be able to speak in details about how we are weaning from cardiopulmonary bypass, what are the different scenarios coming off bypass, and what to do with each scenario. So I promise we will be speaking about this thoroughly next week. But just to catch up and touch base with this, you should have a checklist, at least a mental checklist when you're coming off bypass. And this is one of the points which should have the most important interaction between the surgeon, the anesthetist, and the perfusionist. And you should make sure that the patient is normothermic or more or less normothermic. Your anesthetic have been started, you started your ventilation. If the patient might need inotropes has started. The heart rate is within normal and the rhythm is in sinus rhythm, and you have started your ventilation back on again, and you double check with the perfusionist that the patients have a decent basic CES and the electrolytes are within normal. So is on-pump cardiopulmonary bypass is the only way doing CABG? I would say no. So ironically, off-pump CABG has started since 1960. And in the 70s and 80s, it became less popular with the advances which happened in the cardiopulmonary bypass. However, later on in the late 80s and the early 90s of the last century, more people are becoming more fond of doing off-pump CABG. And the rationale for avoiding cardiopulmonary bypass is to avoid systemic inflammatory response, which can take place with cardiopulmonary bypass, coagulopathy associated with platelet dysfunction, accelerated fibrinolysis and consumption of clotting factor, and finally, neurological injury and renal impairment. Off-pump CABG depends on institutional resources as well as surgical preference. So you will find that most of the surgeons will prefer doing their CABG on cardiopulmonary bypass because it provides them with a stable heart. You have given the heart a cardioplegia and you have a cross clamp, so the heart is not moving and there is no bleeding. So the way that surgeons have overcome the mobility of the heart is using this method, which is octopus stabilizer. So the octopus stabilizer is two paddles which are connected with suction, and by applying these, the suction on at the site that they are requesting here around the coronary that they are going to perform on, this produces a direct pressure on the myocardium, which keep it as stable as it can get, so give them a decent field for them to work on. And the other advance which helps the surgeon as well to reduce the bleeding is this intracoronary shunt. So once the surgeon do a snip here in the coronary, there will be a bleeding. By putting the intracoronary shunt, they will have reduced the risk of bleeding, so the surgeon will have a good field of vision, plus it will maintain the perfusion for the distal part of the myocardium in here, so it will reduce the risk of intracardiac ischemia. The anesthetic goals and management of OPCAP. So if you are starting conventional technique using the induction with the goal that we agreed on, avoiding tachycardia, avoiding hypotension, using high dosage of opioids if needed, volatile anesthetics in order to for maintenance. In contrast to cardiopulmonary bypass, beating heart surgery required anesthetists to maintain stable hemodynamic and heart rate and rhythm as well. And in an environment that changed rapidly because of regional ischemia, because the surgeon will be operating in this coronary, causing occlusion, as there will be regional ischemia and cardiac manipulation as well. Therefore, a good communication is a must in doing this, and adequate pre-medication required to avoid tachycardia. Before the use of stabilizers, bradycardia was very important. However, right now it is less important, but you should avoid tachycardia by all means. And you can use a selective beta blocker like esmolol in order to get a decent heart rate within the normal range. Cardiac displacements increase the risk of intraoperative arrhythmia, especially reperfusing arrhythmias. Therefore, we should be able to maintain as normal serum potassium above 4.5 millimole per liter, and top up magnesium up to 5 grams as long as the patient is tolerating it, because magnesium will produce myocardial stability and reduce the risk of arrhythmia. Anticoagulation. Patients will need heparin as cardiopulmonary bypass, but we will need nearly half the dose. So instead of giving them 300 to 400, usually to go to 100 up to 200 international unit per kg. And our target ECT in here is 250 to 300 seconds. And once the surgeon is already done, then we reverse it with protamine. Hypothermia should be avoided by using of warm IV fluids and active rewarming as well. Management of hemodynamic changes. So the management of these changes involve maintaining a high perfusion pressure, MAP of around 70 if able, and low myocardial oxygen consumption. And as you can see, most of the hemodynamic changes occur as a result of what we can see here in this image. First is applying of the myocardial stabilizer, which will produce a direct pressure on the myocardium, reducing the venous return. Second step, it prevents the myocardium in sharing in the cardiac contractility, so it will reduce your contractility in this bit. The third issue, during displacement of the myocardium, especially they are causing reperfusion in the obtuse marginal or the right coronary artery, the heart will be hanged upside down like you can see in here, which will further reduce your venous return. And in severer cases, in an unexperienced surgeon, this might cause twist in the mitral valve or tricuspid valve, which will cause severe mitral regurg or tricuspid regurg. All of these will be associated with higher risk of hypotension. This should be prevented by maintaining adequate volume with the patient intravascular status, doing Trendelenburg position, which will help increasing venous return from lower half of the body, and providing adequate squeeze using vasopressor like noradrenaline. So which is which, how to you are going to guide it? There are multiple methods that you can use, but the safest and the easiest is using the transvagal echo in order to see the heart, assess the left ventricle. Whether there is a massive regurg, you can ask the surgeon to untwist the heart, and if there is a sign or pictures of a low vascular volume, you can increase your intravascular volume. The only downside of using transvagal echo and off bump, especially in this condition, the images during lifting the heart can be blurred because of the presence of air between the probe and the heart, but in many conditions you will still be able to have a decent images. The National Institute of Health and Clinical Excellence have published their investigation about the outcome of off-pump in comparison to on-pump cardiac surgery. And they have found that the conversion rate to on-pump CABG was nearly 5%, with a range from 0 to 20%. Primary study reported intended to treat mortality. A meta-analysis of nearly 300,000 patients reported that the 30-day mortality was significantly lowering following off-pump in comparison to on-pump. However, in the same publication, they showed that the largest randomized control trial that they had, which included 5,000 patients, it didn't show any change in 30 days mortality. There was no statistical significant difference regarding myocardial infarction or repeat vascularization, whether we used off-pump or on-pump. The only benefit of using OCAP, which was reported in this, was lower risk of a stroke with off-pump and lower risk of AF as well, post-using off-pump cardiac surgery. Once the surgery is done, patient will be transferred asleep, sedated from the theater into the ITU, and the regimen of sedation which is used in the ITU should be started in the theater with giving the patient postoperative analgesia. The concept of the fast-track management of CABG has started since the 70s and 80s, and since the 90s it become well established. And the main idea is early extubation, early mobilization, and early ICU and hospital discharge. And in order to achieve these goals, you should have a preoperative education with the patient, letting the patient know what all the steps that you are going for, from meeting him into the anesthetic room, what he's going to expect when he's waking in the ITU, a proper pain management, and anesthetic technique which is tailored to early extubation and effective postoperative analgesia. Criteria for early extubation for those patients should be normal hernia, normal acid-base balance, stable hemodynamics and minimal support, stable cardiac rhythm, acceptable drain output, because if there is high drain output, you will have the patient to the theaters again, adequate spontaneous tidal volume and rate, and adequate repose and muscle relaxation. Patient is awake, alert, cooperative, and moving all extremities. Postoperative complication in the immediate period in the ITU can be variable from bleeding, and the risk of reoperation or for bleeding in the UK is 2.5%. Stroke, and the risk of stroke is 0.61%. And renal failure, and the risk of requiring renal replacement therapy is 1.6%. I believe these risks should be discussed beforehand. If there is no bleeding, then it's highly advisable to reload the patient with aspirin 6 hours after the CABG, as this has been evident that it improves the graft patency. Day 1 after surgery, depending on the complexity of the CABG, either starting regular dose of aspirin or dual antiplatelet aspirin. There are some evidence, which is not large scale evidence, showing that there might be some benefit of using small dose of rivaroxaban, where this can be a proper plan regarding what are you going to do with the patient since the day that you are seeing the patient, induction, maintenance, and what is your plan regarding weaning from the bypass as well. Thank you.
Thanks very much, Dr. Hatem, for your comprehensive presentation. We have a few questions here, but let me start with a couple of questions actually. The first one, in the center I currently work in, is using tranexamic acid as routine, 2 grams pre and 2 grams post bypass as routine for everyone. I know that there's some adverse effects for every drug there, but is that something you routinely use in your center or not?
Okay, so there are multiple protocols which are used for tranexamic acids. I would say that if the patient is high risk of bleeding, the protocol that we are using, 30 milligrams of tranexamic acids as an induction, followed by 15 milligram per kg as infusion throughout the procedure.
Okay.
Okay, so if the patient is high risk. If the patient is low risk of bleeding, then we will go for your protocol, 2 grams before and 2 grams after coming off bypass.
And to your readings, is there any difference in those protocols in the term of either coagulopathy or hypercoagulability in immediate post-operative period?
So I wouldn't say that there is the protocol which is associated with the higher risk of bleeding, the 30 milligrams and the 15 infusion, has been associated in one of the reports from anesthesiology with higher level of tranexamic acid in the blood, but it always has been associated with low risk of bleeding, and it always has been associated with low risk of blood transfusion. However, as using tranexamic acid, if exceeded 50 milligram per kg, the risk of having seizures in the ITU and the risk of having thrombosis later on for the graft is very high. So at any chance, you shouldn't exceed 50 milligram per kg.
Perfect. So the second question is about the milrinone. I noticed in a lot of centers that they use routinely or almost routinely milrinone when coming out of bypass when there's any impaired contractility. But when I reviewed the literatures, I found that adrenaline is a drug of choice. So I saw a few centers doing adrenaline out of bypass. Few centers are giving the bolus of milrinone, like 0.5 or 1 milligram of milrinone as a bolus, associated with phenylephrine or NORAD increase, just to improve the inotropy. So I need your experience and if you are updated with the research and literature in that regards. Thanks.
Okay. So regarding milrinone and the using of milrinone and adrenaline, in our center, the most common drug which we are using coming off bypass is noradrenaline rather than milrinone or adrenaline, as long as the patients have a decent contractility, just to avoid the vasopressure coming off the bypass. So noradrenaline is the routine medication which we use. If the patients have a mild LV dysfunction, we use dopamine, and if the patients have an RV dysfunction, then we go for milrinone. Adrenaline is only for severe patients because it's a risk of having a metabolic acidosis as well as the risk of increasing your BMs is very high. Regarding if there is a report regarding milrinone and adrenaline, I believe that they are comparable, but you always have to put in mind the risk of hypotension and the vasoplegia, which is associated with milrinone. So it's totally dependent on the practitioner and the anesthetist who's doing the surgery.
Perfect. So we have a few questions here from our attendees. The first one is Muhammad Khayyai, I don't know if I'm pronouncing right, using non-steroidals for post-operative pain management in intensive care unit. What do you think?
Okay, so using non-steroidal has been associated with increased risk of thrombosis in these patients. So using ibuprofen together with paracetamol or aspirin is not advised in patients immediately post CABG. And most of these patients, if they are going for analgesic, they are dependent on what is the protocol. In our units, the protocol is using morphine initially or oxycodons, and later on just the paracetamol and the hydrocodone. But I wouldn't advise giving the patient non-steroidal plus paracetamol. It is not advised after CABG.
Okay, so question from Burhan Kazal to Dr. Hatem. If the patient has left main or bad LAD collapsed in the cath lab during percutaneous intervention, how much time it would take you to put him on the pump? It's a bit difficult question. I think it's a logistic question, but
yeah,
you have an input.
So it depends on the cooperation of the whole team. As you see, it's a logistic question, but in our experience, it takes around half an hour to 45 minutes in order to get everything in place and transfer the patient from the cath lab into the theater and starting the surgery. But putting him to the pump, it will take an additional 15 to 20 minutes as well.
Okay, from Ain Abu Ghali, the question may not be so clear, so I will just say it as is and may discuss it if you have any input. Is fast track can be applied on the on-pump CABG? I think fast track is applied either on pump or off pump.
Yeah.
So it does not. The fast track is extubation within a certain period of time, which is few hours, less than 12 hours from the bypass. Am I right?
Yes, indeed.
Okay. So it's not related to on-pump or off-pump CABGs.
So fast track is not attributed to the surgical technique which is done. It's more attributed regarding your protocol of induction and the maintenance of the analgesia which you are going to do. And it's highly advisable. As I said, it reduces the risk, the staying in the ITU, and reduce the time of the ventilation as well.
From a question from Basim Yahya, maybe I didn't hear about that before, but I'm seeking your input as well. Is extubating CABG intraoperatively more better or sending patient intubated to ICU?
Okay. There are some reports about ultra-fast track, what they are calling it ultra-fast track, about extubating the patient in the theater. However, there is no evidence about the benefits of having extubating the patient in the theater rather than in the ITU. Doing that, you might jeopardize anesthetizing the patient again if the patient starts to bleed a few hours after the operation and you want to re-operate on him again. So there is no benefit and you're increasing the harm to the patient, so there is no point in doing that.
Muhammad Ali Hassan is asking, I have studied tramadol infusion in post-operative open heart for pain controlling in ICU after valvular surgery or valvular heart disease surgery. What about post-CABG?
Tramadol.
Tramadol infusion.
Okay, so I haven't read anything about the using tramadol infusion, I'm sorry, regarding CABG, and it is not a common protocol that we are using as well.
Okay, perfect. So from our panelists and professors here, kindly unmute yourselves and ask your question if you have any. Prof. Muhammad Ibrahim, Prof. Mabdi Khalil, Dr. Amr Hashim.
Thank you very much for this very comprehensive, simple and highly rated presentation as well at the same time. So I enjoyed it very much, and it didn't miss any point. Just asking about your experience and personal experience as well as your center experience with the off-pump CABG. So you mentioned here that the main benefit is from the evidence is regarding the stroke. So I had to know that this the main benefits before were the bleeding risks, and still there is risk of stroke and renal impairment, especially with, you said, with the maneuvers of manipulation of the heart and maybe hypotension and using vasopressors on and off, and swinging in the blood pressure, swinging in the inotropic levels, and in the blood pressure as well. So can you tell me about your experience about it?
So I'm sorry, I missed the question. Is it related to the risk of bleeding in of pump?
Yes, yes. You mentioned that the main benefit is that less incidence of stroke.
Yeah.
I happen to know that the main benefit was less incidence of bleeding, but still there is an incidence of stroke and renal dysfunction because of the swinging in the hemodynamics during the off-pump cardiac surgery.
Okay, I just have to declare that this is the NICE outcome, which have been declared in 2016, 2017, about the outcome of the off-pump versus the on-pump. Risk of rebleeding and risk of bleeding in general, post off-pump versus on-pump, hasn't been declared in that. In our center, the risk of bleeding post off-pump is almost minimal for those patients. The risk of reoperating again exists because you will still have the lima beds and you will still have the target if they are going to bleed and if there is any surgical insufficiency. However, I would say that it's more or less, but it hasn't been attributed as evidence in the NICE guidelines.
I would like to thank you very much as well for highlighting the importance of the transesophageal echo and the new monitors like the NIRS or the INVOS use. Especially many centers still they are not a fan of using the TOE in CABG patients, and they are just keeping them for valves only or the combined surgeries. But I thank you very much for highlighting that the TOE can give us a very, very important information, and they can give us clues as well for many of the incidences and the issues that we meet with these patients during the operation. And that's the same, in my opinion, with the NIRS and the INVOS as well, and the headsets, that sometimes you can find the unexpected with these patients. Definitely. And these monitors can give you the clue. And I can say that I like to say that whenever you have a probe, you should put it in the patient if the TOE. Thank you so much for
I totally agree with that. Thank you.
Very comprehensive presentation.
Hatem, a couple of more questions. Any professors or panelists are interested in any question here? Please unmute yourself and go ahead. We still have a couple of questions here from attendees. A patient with severely impaired ejection fraction, what do you use for induction? What precautions do you take? Should we prepare, for example, femoral cannulation or use intra-aortic balloon in the pre-op?
Okay. So it's quite common that you can anesthetize patients with ejection fraction down to 15%, 10% or something like that. You will be able to see those patients coming on. What are my preference for anesthetizing these patients? I would say higher dose of opioid. I will go 5 to 10 mics per kg. Fentanyl, I will put some benzodiazepines as well, 0.5 to 0.1 milligram per kg of benzodiazepines. Titrating these drugs to the best, as well as to anesthetizing the patient till they are asleep. I would say that the key point in these patients is to titrate it as slow as you can, because all these patients are elderly. Most of these patients have a sluggish circulation as well, so they will need more time. Give them very tiny dose of propofol, maybe 10, 20 milligrams, more than enough for them. But most of the patients will be asleep just with the benzos and opiates. Putting a femoral line for those patients, I strongly recommend this, and this is our routine in high-risk patients. So if a patient with low ejection fraction, usually we put 2 arterial lines, one radially and the other one is femorally, just in case of intra-aortic balloon if needed later on. Whether to put these patients in intra-aortic balloon or not, this will be a decision which should be conducted with a cardiologist and a cardiac surgeon beforehand. But definitely, if the patient is in cardiogenic shock beforehand, these patients will be in an intra-aortic balloon before I see them. PA, pulmonary artery catheter as well, can be beneficial if you are subjected, considering that these patients might come off on multiple inotropes and intra-aortic balloon. It will not give you absolute ideas in the theater, but it will help you definitely when you are weaning your inotropes later in the ITU.
Dr. Hatem, I would repeat my thanks very much for
just with this point, Dr. Walid.
Yes,
there's asking about the because the some studies use the levosimendan as well at the beginning of the anesthesia, and the patient with very low ejection fractions less than 30%, and some of these studies has encouraging results with these patients on coming off bypass easier. Rather than using an intra-aortic balloon pump. I don't know if Dr. Hatem has something to say about it.
So we don't use levosimendan much in our center, so I'm not able to comment on that. But definitely there is evidence about it, but personally I haven't participated in that.
So like if the patient is complicated by hypotension in post-CABG surgeries, there's a lot of tubes and lines. It's a bit difficult. So will you try transthoracic echo first, or you will go ahead and do the transphageal echo straightforward after that?
Okay.
From your own experience.
So in our units, doing transthoracic echo is the first thing that should be done in any patient who having hypotension. We will try doing TTE first. Although, as you say, it's quite difficult having all of these lines, having chest wall edema as well will reduce your visibility, so you'll not be able to see all the images as crystal clear as you want, but at least you will have a clue about what you are searching for. So in these patients, you are searching about contractility, whether the heart is still contracting or not. You are searching about pericardial tamponading, so you will searching for a tamponade or not, and you will be searching whether there is a collection in the pleurus in both sides or not. These are the questions that you are asking for. If you know what are the questions, you will be targeting them, and if you have just a hint, you will be able to manage across. So I will go for TTE first. If I had good images or a decent images which answer my questions, I will be satisfied with that. Because TOA doesn't come without risk and without complication. We all know that there is a risk of esophageal perforation 1 in 70,000, which should be discussed. So putting them in an elderly patient, multiple goes and goes and goes, is not come without any risk. So I will try TTE first, definitely.
So even like in our units practice, every or almost every cardiothoracic surgeon, he knows, and he took a course, at least one course on transthoracic echo, so he can put the probe himself. And if he is in doubt, he asks us for our help. And if we didn't get an answer with transthoracic echo, we could Prof. Muhammad Ibrahim